All right, it's a little bit after 1 p.m., so to be respectful of everybody's time, we're going to go ahead and start. Welcome to the Fluid Forum, a panel discussion on pediatric ultrafiltration with Aquadex. Next slide, please. Right. You'll see here the slide. I will save everybody the pain of reading it to you verbatim, but this is the forward-looking statements from New Wellness as a corporation about itself and about the Aquadex SmartFlow System. Next slide. Okay, well, this afternoon we're going to cover five major areas. We're going to understand pediatric ultrafiltration. We're going to discuss the pediatric patients that are in need of Aquadex. We'll talk about access options for pediatric patients. We'll talk about safely anticoagulating the pediatric patient receiving Aquadex therapy, and then hopefully a robust question and answer session at the end. Next slide. My name is David Cooper. I'm a pediatric cardiologist and intensivist at Cincinnati Children's Hospital. And I have the honor of moderating this webinar series with four outstanding colleagues with expertise in critical care nephrology. First is Dana Fuhrman. Dr. Fuhrman is a pediatric nephrologist and intensivist who now works with me at Cincinnati Children's Hospital and previously at UPMC Children's Hospital of Pittsburgh. She is the board certified in pediatrics, pediatric critical care, and pediatric nephrology, and is an associate professor here with us in the Division of Critical Care. She helps to lead our Center for Acute Care Nephrology here at Cincinnati and has been a clinical investigator in the realm of renal replacement therapy and critical care nephrology for over a decade. Next, we have Kyle Merrill. Kyle is an assistant professor of pediatrics and a pediatric nephrologist at the Steed Family Children's Hospital at the University of Iowa. He completed his fellowship here at Cincinnati in nephrology and also holds an MS in clinical and translational research from the University of Cincinnati. Next, we have Dr. Michelle Starr. Dr. Starr is at Indiana University School of Medicine and a practicing pediatric nephrologist at Riley Children's Hospital, IU Health in Indianapolis. She has been a longtime investigator in various areas of nephrology and will share her expertise with us. Teresa Modis is an acute care pediatric nurse practitioner in nephrology at the Ann and Robert Lurie Children's Hospital of Chicago. She has more than a decade of NP experience and more than 25 years of pediatric nephrology experience, and she leads dialysis, CRT, dialysis education, and acute renal support therapies, and is considered a global expert in such. And then lastly, we have Kelsey Newell, who is the Senior Director of Medical Affairs for New Wellness, and she's available today if there's any business questions that you may have during the session. Next slide. So first, we'll start off with a bit about understanding the fluid problem and Aquadex as a solution. Next slide. So to those of you on the webinar, this would not be a big shocker. These are the various causes of hypervolemia or fluid overload. There's pediatric heart surgery, nephrotic syndrome, congestive heart failure, native and primary kidney disease, those that have undergone solid organ and bone marrow transplantation, sepsis, and severe burns. Next slide. Likewise, in this various clinical conditions, fluid overload is associated with significant increases in mortality in pediatric patients. Fluid overload is an independent risk factor for acute kidney injury in critically ill patients. In a pediatric study, a 3% increase in mortality was observed for every 1% increase in fluid overload. Children with greater than 20% fluid overload had an odds ratio of mortality of 8.5 compared to those with less than 20% fluid overload. And in children greater than 20 kilograms treated with Aquadex in the Ultra Peds registry, fluid overload was independently associated with decreased hospital and ICU length of stay and mortality. These are just a sampling of studies that remind us of the clinical significance of fluid overload. It is not just cosmetic, and it is, and treatment of this disease state has important clinical ramifications. Next slide. So there are, of course, clinical indications for pediatric ultrafiltration, and ultrafiltration may be appropriate for pediatric patients who meet one or multiple of the following criteria. So persistent fluid overload despite escalating diuretics, volume overload contributing to respiratory support needs, cardiorenal syndrome impacting recovery, post-cardiac surgery fluid retention that is unresponsive to diuretics and delaying forward progress, recurrent admissions tied to fluid management challenges, particularly in those with congestive heart failure, inability to maintain target fluid balance in the outpatient setting despite diuretic management. So gaps in efficacy expose a major opportunity. Early identification of diuretic-resistant patients and intervention with ultrafiltration can change the course of care for these patients. Next slide. So as far as Aquadex SmartFlow goes, this system is indicated for continuous ultrafiltration therapy for temporary up to 8 hours or extended longer than 8 hours in patients who require hospitalization in adult and pediatric patients weighing more than 20 kilograms whose fluid overload is unresponsive to medical management, including diuretics. All treatments must be administered by a healthcare provider within an outpatient or inpatient clinical setting under physician prescription, both of whom having received training in extracorporeal therapies. Next slide. This is a bit of a close-up of the Aqueduct SmartFlow system, which I'm sure everyone is familiar with. These are three great qualities of that system. It is safe. It is effective for pediatric patients weighing more than 20 kilograms. It requires only about 35 milliliters of extracorporeal blood volume. It allows low blood flow rates of only 10 to 40 mils per minute, which can help avoid hemodynamic stress of excessive fluid shifts and fluid removement. And a low maximal ultrafiltration rate of 500 mils per hour reduces risk in smaller patients. It is quote unquote gentle. It's as an alternative to diuretics, as an alternative when diuretics or CRT are ineffective, poorly tolerated, or less efficient. And it is technically smart. There's a filter alert that helps extend the life of that filter and reduce treatment time. There's a crit line that supports titration and therapy decision making. There's a place to measure SpO2 that helps guide oxygen delivery and therapy choices, and will automatically track the fluid removed for accuracy. Next slide. So this is how the Aqueduct system works. Their blood is taken from the patient via the withdrawal line using a catheter. That blood is pushed through the filter by a blood pump at about 10 to 40 mils per minute. That ultrafiltration pump then withdraws the fluid across the filter membrane using negative pressure. And as I said before, there's a hematocrit sensor that monitors the patient's preset hematocrit limits and can help guide therapy. And the ultrafiltration pump can pull it can pull exactly 0 to 500 mils of fluid per hour. So very safe, effective, and efficient. Next slide. So I mentioned this study before, the Ultra Peds study. So in this study, there was a 92% survival in children with acute kidney injury, fluid overload, or congenital kidney failure following treatment with Aquadex. The Ultra Peds study had 91 pediatric patients across 8 U.S. centers. These included about a third of the patients had congenital heart disease, 25% had end-stage renal disease, and 14% of these patients had malignancy. And like I said before, 92% of these patients survived their Aquadex treatment course, and 66% survived to discharge. Next. Okay, I will turn the presentation over to Dr. Starr, who will talk about pediatric patients in need of Aquadex. Michelle.
Perfect. Thanks, Dr. Cooper. So I am going to, along with a couple of my colleagues, talk a little bit about who we put on Aquadex therapy. Next slide, please. So institutional experience does certainly vary in terms of the patients that we have all had the most success and the most experience with. And really the program looks different at every single pediatric hospital. But I will talk a little bit about who we treat here at Lurie and then, or sorry, Riley, and then I will hand it off to everybody else to talk about their experiences. So here at Riley Children's in Indianapolis, Indiana, we treat patients across all of our ICUs. We take care of patients in the PICU. Our most common patient types are those with bone marrow transplant, particularly those complicated by vaso-occlusive disease, in which we actually have a dialysis catheter that is available to perform Aquadex therapy placed at the time of their stem cell transplant. We also treat a lot of nephrotics with either acute kidney injury or fluid overload that is diuretic resistance. We are often starting therapy in our CVICU for a variety of disease states and operative states as well. And also in our neonatal ICU, where we treat infants with congenital kidney abnormalities as well as congenital kidney failure. And then I'll pass it to Teresa to talk about Lurie.
Thank you. At Lurie, we are currently just getting our program off the runway. And so we're really just dabbling and really exploring. For us, we have treated in the PICU both nephrotic syndrome as well as some CKD patients who in between the HD or CRT needed additional fluid removal. I would say our biggest patient population right now is our cardiac patient population, both surgical, post-transplant, and then we've had one patient that we did sepsis with ECMO as well. So that's our particular patient population at this time.
At Iowa, we are much like Teresa at Lurie. We just recently got our program up and running, and have treated a lot of similar patients. Our PICU patients primarily being a patient with a bone marrow transplant who had AKI and fluid overload, as well as in our cardiac ICU, some patients with acute heart failure. And then one interesting patient we treated was a patient with heart failure who had chronic diuretic resistant fluid overload, and had a pulmonary artery pressure monitor in place, in which our cardiac team can monitor and learn when they were excessively fluid overloaded, and we were able to provide some diuresis for them.
And I'll speak to UPMC Children's Hospital of Pittsburgh's experience. As Dr. Cooper mentioned, I recently transitioned to Cincinnati Children's, but today I'm going to be talking about my experiences in Pittsburgh. And our program in Pittsburgh, one of the, I think, great joys of my time there was when we started using Aquadex, which we are about 4 years out in starting our program. And I will say the first patients that we started using it in, being a large solid organ transplant program, were those exact patients. Multitude of reasons for needing the therapy, especially in our smaller patients. BMT patients, as Dr. Starr mentioned, solid or nephrotic patients with nephrotic syndrome, sepsis, and similarly, our cardiac ICU became a rapid adopter of Aquadex therapy, not surprising for the purposes of scuff. And then our neonatal ICU has also come to use it more frequently for similar reasons. I'll talk a little bit more in detail about the use specifically in these areas when I talk about anticoagulation.
Next slide, please. All right, so I'm going to talk a little bit about our experience here at Riley Children's. So we started our Aquadex program in early 2020, and we really treat a variety, like I said, a variety of patients across all of our ICUs. We have grown from when our program started, we were just in our pediatric ICU, and now we expand into all three of our ICUs, so the pediatric ICU, the cardiac, and the neonatal. In terms of kind of our most common patients treated, I'm going to speak a little bit more about nephrotic syndrome, but we have had really good experience treating children with nephrotic syndrome, particularly those with fluid overload that is diuretic resistant, as often can really be difficult when patients are hypoalbuminemic and have the significant third spacing, or those that have acute kidney injury. Our first patient that we did this with had severe AKI with tachytoxicity, but was so fluid overloaded, we really were having difficulties with vascular access. So I'll talk a little bit about why nephrotic syndrome really worked well with the Aquadex system. We also treat, like others had already mentioned, a lot of children with congenital heart disease. We do quite a bit of therapy in our NICU, including both acute for acute kidney injury and fluid overload, particularly in those with chronic lung disease, as well as more chronic bridge therapy to longer term dialysis in those with congenital kidney failure. And we also treat a large volume of children with bone marrow transplant. So we have developed a fluid overload program for our bone marrow transplant patients, which, as I spoke a little bit about earlier, includes placing their line that they get for the bone marrow transplant, placing something that is able to provide Aquadex therapy when it's indicated. We have kind of lower thresholds and triggers given their predilection to fluid overload and for acute kidney injury. And so this now takes a pretty significant percentage of our Aquadex days as patients with bone marrow transplant and VOD. In terms of our clinical indications for ultrafiltration, we are often using UF alone in our nephrotics. And I have my next slide is about guided ultrafiltration with albumin. And so we'll talk a little bit more about that. We often, especially as our program has expanded and we have gotten more comfortable with different ways of providing dialytic access, which Dr. Merrill will talk about in a little bit, we have been able to use smaller lines in smaller children. As I mentioned, we are using this earlier. So when children with VOD or bone marrow transplant are 5% fluid overloaded and they are diuretic resistant, as opposed to waiting for them to have respiratory failure and needing it to be more of an urgent or emergent indication. We do not have true thresholds or cutoffs for indication for initiation of aqua, but we really find that the ability to monitor intravascular volume using the crit line is a really helpful added tool. At Riley, we are most commonly using continuous therapy. We do not often use PERT or periodic intermittent renal replacement therapy, but we are often doing continuous 24-hour therapy. In patients that we are treating with albumin and using it as an ultrafiltration only device, we are sometimes using it as an intermittent therapy device. Next slide. I do want to particularly highlight our experience with nephrotic syndrome because I think that this is a little bit unique, but also one of the situations it's one of the most fun I have had in terms of guided ultrafiltration, but really allows you to target therapy very well. So I will point those who are interested. This is from a publication which we presented a case series of children in which we provided Aquadex therapy with albumin. The way this basically works is that for those with nephrotic syndrome and fluid overload or AKI, when they have hypoalbuminemia, you give them intermittent doses of albumin, and then you use your crit line to really guide your ultrafiltration. And we have a protocol that we use for this, which is in the manuscript, and I'm also happy to share, where we are increasing our ultrafiltration rate based on the crit line. And so you are basically determining your ultrafiltration based on what is happening in the patient's intravascular space. It's incredibly effective. It allows you to guide your ultrafiltration and really have very successful volume removal without all of the complications of trying to remove fluid in a patient that does not have the intravascular volume to give. So this was our first 5 patients that we treated with this. We have now treated, I would say, at least 10 patients with a similar protocol. This allows us to decrease the severity of their fluid overload. In several of these patients, this allowed us to keep them extubated or to get them extubated quicker, decrease their length of stay in the ICU, and often will reduce the burden of their acute kidney injury as well. Next slide. So in terms of our experiences, so I would say that we have a moderately mature program. So, we are about 5 or 6 years in. In terms of our impacts and our outcomes, we really are seeing shortened length of stay. And I really want to highlight both in our nephrotic syndrome patient population and our BMT and volume VOD patients that early recognition, early identification of patients who would benefit from either ultrafiltration or targeted therapy really has been kind of one of our greatest successes here. It has been a kind of a lot of growth in terms of our understanding of how best to identify these patients, which has included a lot of coordination of workflows between all of our ICUs, our subspecialty groups, those who are helping us with vascular access, and really starting kind of the program small has been kind of, I think, one of our greatest successes. So we started in our PICU only. We got comfortable with our vascular access, with our protocols and our workflows, and then we have built on our success slowly. In terms of kind of our ongoing work and kind of who is involved, this is considered part of our acute dialysis program, just like I would say most of the others on the call. But we continue to involve all of the stakeholders in all of the ICUs. But this also includes our subspecialties that are more frequent utilizers. So folks like our oncology colleagues, our bone marrow transplant colleagues, and then our heart failure team as well. And I think one of the things that's a little bit unique is that the way our program works is that the ultrafiltration is managed primarily by the ICU with impact from nephrology. And so there's been a lot of shared learning and shared decision making on how we guide ultrafiltration in children based on the hematocrit line. Next slide. So with that, I will pass it over to Teresa.
Teresa, before you start, let me just ask Dr. Starr to address a couple of questions specifically to the information she shared. So, Michelle, there's a question that came along asking, are there any thrombotic issues with diuretic resistant patient in nephrotic syndrome getting a small caliber line?
So it's a great question. We had one patient who had a thrombus who was a nephrotic, but for the most part, we have had really good success. These are patients, and Dr. Fuhrman's going to talk about anticoagulation, but most of these patients we are anticoagulating because of their underlying nephrotic and their kind of their overall clinical picture. So I would say 75% of these patients, the nephrotic group, we are treating with heparin when we perform Aquadex. But I would say of our 10 plus, we have only had one issue with line.
And then one other, maybe two other questions. One is, are you doing any blood priming of the system for neonates when you use it in the NICU?
So yes, and it's really just based on size and clinical hemodynamic stability. Our usual threshold is 4 kilograms. That's what we use at Riley. We have simplified all of our blood prime protocols to scale down from our larger circuits. So we basically just take our blood prime protocols and just scale them down to the smaller filter volume. And so we basically use the same approach. My experience with building out our CRT program in general, but also particularly our Aquadex program, has been to just keep as much consistency as we can between device and between a different situation. And so we have tried to keep as much the same as we can.
And then one last question from a participant who's currently using PrismaFlex for their CRT, but are looking to perhaps switch to the Aquadex machine. Can you explain the difference in the machines as far as the ability to do CVVH or CVVHD?
Yeah, so I'm happy to answer that. So, and then someone else can jump in if they would like to. So Aquadex cannot perform a diffusive clearance based on the way that the membrane and the filter is set up. It can only perform convective clearance. So with Aquadex as kind of prescribed without replacement fluids, provides only scuff for ultrafiltration. It can be modified to perform CVVH, but cannot perform CVVHD and cannot perform CVVHDF based on the way
Yes.
it is set up. In our experience at Riley, we are using it about 75% of the time in CVVH, depending on the patient population, but then we are using it for ultrafiltration or scuff alone in those with bone marrow transplant, VOD, our cardiac kids, and then our nephrotics as well.
Great. Thank you, Dr. Starr. All right, Teresa, you're up.
All right. I will take it here from the Lurie experience. Again, we are about 2 years into this. We rolled out in our cardiac patient population and have now started to expand our population to the nephrotic syndrome and then also transplant. One patient population, and we're excited to hear Michelle's experience, is the stem cell transplant, the VOD patient population that we have been in conversations with our partners about how to manage these patients and potentially use Aquadex a little bit earlier. I think for indications, it's really relatively the same as probably all four of us on the call. It's failing diuretic therapy, fluid overload that has a clinical impact. And it's also those patient populations that have fluid overload, but maybe do not have significant azotemia or electrolyte disturbances that we need clearance for. Although I am going to highlight a case that was of interest to us in our cardiac patient population. From a treatment approach, at this time, we are using dialysis catheters. I will share that we had attempted to use the PIC early on, but learned and talking with Michelle Starr about her program, sort of getting good at what we were doing and then exploring a little bit further. So we have shifted back to using all dialysis catheters at this time, and then are now starting to explore other opportunities. From a treatment approach, we typically do continuous. However, we are now starting to have those discussions about 6 to 8 hour treatment lengths. As far as our UFs, we sort of have a max UF that is 50 mLs per kilo per day. It's extrapolated from the CRT literature using that 2 mLs per kilo per hour. And it just gives us a guideline, but we really actually follow our hematocrit changes that really guides us to where we want to go from a goal. We talk a lot about when we're approaching this with our colleagues, we talk a lot about what is our ultimate weight goal for the next day, and then take into consideration what they're getting in as well as what they're already putting out. Because one of the things that we have found with our experience with Aquadex is that depending on how we're ultrafiltrating, we have been able to preserve our renal function as well as preserve our urine output that we also don't see with some of our CRT patient populations. Next slide. And this is that case that I just wanted to highlight. This was a cardiac, a congenital heart disease patient that we were consulted on probably about 5 days before we actually started a therapy. Initially managed with Bumex. You can see that each day we were going up on the Bumex infusion. You can also see that this patient was making a fair amount of urine, but the intakes were exceeding what the urine output could manage. But as we went up on the diuretic therapy, we weren't seeing as robust urine response. But in addition, that line, that orange line that's climbing, that is the BUN. And it started to get into the mid to, I think it was 84 when the Bumex was then decreased to 2, but we saw a decrease in urine output. Bumex was increased again. And then ultimately the conversation at this point, this patient's making fairly decent urine, but still significantly fluid overloaded at about 30% fluid overloaded. We had a lot of conversation and there was a big decision point. This patient had a BUN in the 80s, but still making really robust urine, having some response to diuretics. And we felt like this would be an opportunity to try Aquadex to see how we could respond, how this patient would respond, knowing that we had other therapies in our back pocket should this not progress. But you can see as we removed fluid, so we started Aquadex there. We did leave the Bumex on at a much lower dose. I'm sure that that is a point that we could debate. But we felt like this patient was very diuretic dependent and very concerned that if we had stopped the diuretics completely, that may have impacted the clinical picture. But we started Aquadex slowly removing with a net goal of removing 200 to 250 per day. And what we found was that the kidney function as well as the BUN got better with ultrafiltration alone. And we were able to preserve the urine output. Yes, we did have an impact on the urine output, but the urine output continued to be pretty decent. And as we got closer to our estimated dry weight, and we backed off on our Aquadex, the urine output came back without the higher doses of diuretics. Ultimately, this patient several days later developed a progressive course and did go on to CRT. But this really highlighted to us that for 4 days of Aquadex, we were able to achieve a pretty decent weight without having clearance and actually improving our kidney function and our electrolyte or our BUN overall. Next slide. The other thing that we did also highlight with this particular patient was really looking at the CVPs. And as we were making an impact here where our CVP was 18, and our hematocrit was about 38, as this patient was shifting fluid from the extravascular space into the intravascular space, our CVPs were rising as well, which gave us an opportunity to increase our ultrafiltration, which I think is the real benefit of doing ultrafiltration with that hematocrit monitor. Dr. Starr has already mentioned the value in that, but having that sort of real-time intravascular assessment really allowed us to make adjustments appropriately. Where we did run into trouble and had to do some resets is when we did do we had to transfuse, and you can see that that hematocrit went way up, and then we were able to reset. But this for us was a great experience, really sort of understanding how fluid's shifting, when to respond, and the impact that it had on actually the kidney function with an improvement. Next slide. And so for us, the overall improvement in our and impact, we've certainly been able to have a better control over fluid balance with less impact on that kidney function and urine output that has been described in the literature. There's some great literature that shows even with lower ultrafiltration rates, when paired with clearance, that there is an effect on urine output. Not completely understanding that, but it's been certainly been reported. We've had this tolerated very well. We've used a very numerous amounts of different types of anticoagulation, but I'll let Dr. Fuhrman talk about that. From us, really understanding the lessons we learned was sort of moving from this net negative per hour to a goal per day really helped us understand how to preserve urine output, but still maximize fluid removal. And really where things we're looking at now is sort of shifting to developing a protocol for UF adjustments based on that hematocrit. Right now, it requires someone to come back in and sort of adjust that or get notified, but we're working on making this a little bit more standardized. I would echo Dr. Starr's comments that as much standardization that you can do across the board has really helped, that we are now rolling out into the PICU, and then potentially looking at doing this outside of the critical care areas. I'll keep you up to date on that. We're really excited about the opportunities. And then as far as our teams involved, it's really that primary service in nephrology right now, really our PICU and cardiology our consult collaborators, and then our ADAPT RN team, which is our dialysis and pheresis procedural team that is in-house 24/7. There are stars that keep everything running for us. Next slide. I'm going to turn it now over to Kyle, who's going to talk about
Great. Before Kyle starts, let me just share with the group some important questions that were asked and answered through the chat mechanism. So one of the attendees asked, we've had issues with accuracy of the reported ultrafiltration from hour to hour, and therefore have ended up removing significantly more or less food than intended. Do others have experience with this? Dr. Starr was able to answer this question, noting that this is seen on occasion, especially with line issues or smaller kids or lower blood flows, but they've used a daily, twice daily weight check and using the crit line as a second double check on volume status. And I would emphasize that crit line is really good at letting you know what your volume status is practically. Another question was, are you guys using calculated dose or estimated daily weight for UF goals? I'm sorry, estimated dry weight. And Dr. Stride indicated they use estimated dry weight and or admission weight usually to guide therapy. And then lastly, in critically ill patients in CVVH receiving blood products, how do you manage the interruption of the UF pump when hematocrit increases? And the standard protocol at O'Reilly is to dock the hematocrit sensor during and after blood products and then baseline after blood products have been administered. So three good questions, three great answers. There are a number of other questions. Don't worry, we've not forgotten you, but they're going to be answered in the flow of the talk. But I promise you that we'll get to them if they are not answered by our speakers over the next sections of the presentation. All right, Dr. Merrill, take it away.
Awesome. Thanks, Dr. Cooper. So we're going to now focus on once you've kind of figured out who in your patient population you're going to do this on, how are you going to actually perform the therapy? So next slide, and we'll talk about a little bit of the access options. And so I think to kind of go back to what Dr. Cooper mentioned about how this is safe, gentle, and effective, the key point there being it is gentle and that you don't need robust blood flow rates to allow this machine and this device to run well. Um, and so we just wanted to highlight a few of the options. And I think what I'm going to focus here on is the idea that you don't necessarily need to have central access to perform this therapy. There are some variety of peripheral access options, and I think if you ask all four of us what we're doing at our institutions, we're probably all doing for slightly different things. And that's the beauty of this is you can figure out what works for your team. Um, and so just start the topic. One option is central access. You can use a CVC, whether that's a truly apheresis capable catheter or a central line that is already in place that may have a lumen that's greater than a 14 or 16 gauge in which you could use for one of your access points. But you can also use peripheral access. Now, Nuwellis has the DELT catheter, which is that second kind of line there, which is their, I think it stands for dual extended lumen catheter. That's a rigid catheter. It's coil reinforced. It's available in 11 or 15 centimeter lengths, and it can be inserted peripherally. And it works really well with the blood flows that you need for this. The other option, and I will admit I don't have as much experience with this one, is one of the Bard Power Midline or Power Picks. That's a 5 French catheter, and no, those typically are fairly long, and so it's recommended to trim those to about 10 centimeters or less because the longer the catheter is, the harder it is to sort of flow at these higher blood flows. Um, but your third option for peripheral access is actually using the BD Nexiva Diffusix IVs. These are the IVs that are commonly inserted for and considered like power injectable IVs or contrasted IVs for CT imaging, as they've got some added holes in the end of the catheter that can allow for better blood flow. They all have their variety of manufacturer recommended use duration. And so that may play a role in what you're thinking about with all of this. And then also who can place them. The key point being some of these peripheral lines or access points can be either placed by a nurse or a vascular access team versus a physician maybe having to do the more central access. They all have different key considerations. But I think the highest one that we'll point out is that the DELC was designed for the Aquadex itself, and all these others are modified access points. Next slide. When thinking through these access points, and I will do my best to explain this as much as Kelsey has explained it to me, but this is a figure that looks at typically your blood flow setting and then your catheter flow rating. And this kind of looks at, is your catheter big enough to do the flows that you want, or do you need to consider smaller flows or things like this? And the key point here is that you want your catheter to kind of fall in this middle point, which is the A point. And so, yeah, Devin, if you want to go ahead and next to get all three of them up there. Each one of these points kind of highlights where each of these catheter options are, the Bard midline, the Delc, and the BD Nexiva. And so you can see that some of those catheters are rated for a little bit of a higher flow rate that are the bigger ones like the Delc and the Bard. And so this is key of just figuring out what your access point is going to be and where it is on this, because you might actually find that, let's say you put a Bard in, and or not the Bard, I'm sorry, the BD Nexiva in, and you run into issues running it a little bit too fast. You may have to drop down your blood flow on that. But this kind of provides a guide, but not necessarily true limits on based on just kind of experience. So, next slide. So I was going to talk about kind of three of our patients that we have looked at and treated with this. And so our first patient was that we did performed Aqua on was our heart failure with recurrent fluid overload. We actually placed a peripheral DELC and then ran into some issues with that catheter that have then been mitigated. And so the second day, we were unable to use the DELC, and the patient was able to convince our team, which you can't say no to a kid asking you to consider something else. And we put 22 of the 20 gauge BD Diffusix IVs in, and was able to work that well in two different arms. And so our goal initially was to use the coil reinforced DELC catheter. But we worked with what we had. And so I would say the Delc itself had no issues with maximal blood flow of 40 mils a minute. It worked well. Um, versus the Diffusix also initially worked well, running at a max blood flow rate of 40 mils per minute. The patient themselves was complaining that I believe the words they used were their vein felt like it was vibrating. And so we decreased down to 25 mils a minute, and the patient managed the therapy as well, to the point where we were debating doing it second treatment at a future admission. And when I talked to the patient about doing it, they asked if they could do the peripheral IVs instead of the bigger catheter. And so I think that goes to say something of when the patient's able to say like what they want and what they preferred better. And what I learned from that was that the PIVs are options for access and provides a nice change from what historically is needed to perform ultrafiltration. And we learned there at that point that we were going to consider placing both access points in the same arm, putting the withdrawal in the upper arm, where the vein lumen caliber is bigger versus the infusion in the lower arm. We also performed this on a patient with a bone marrow transplant, who was already on CRRT, and so they had a 10 French 10 French 15 centimeter in their IJ. The reason we used it was already there. We weren't going to add anything else. We noted that there were some alarms though with the withdrawal and infusion, where they were concerned that the machine had disconnected. So we added in some Hoffman clamps on the access point and on the circuit to increase the resistance, and learn from that that sometimes these lumens can just be too big and the machine thinks that you're, not pushing or pulling against any resistance, and so it worries. The last patient I want to highlight is an acute left ventricular heart failure. We attempted a PIV, but had unsuccessful use of the PIV mostly because it was clotting, and then we attempted a lumen of a 4 French central line. This patient just had really difficult access, and it took hours sitting at the bedside with the ICU team and our cardiac anesthesia team trying to figure things out. Um, and we were able to kind of medically manage for a few days. And then once we were able to get the DELC in, the patient ultimately needed clearance. And at our center, we only use the Aquadex for ultrafiltration. And so they ended up using that for CRRT. Um, And we learned on this one that the lumen size of the double lumen central line can impact flow, and really being cognizant of which lumen is which and which you're choosing to perform or use as your withdrawal line or your infusion line. Um, Next slide. And so with all of that, we kind of haven't formalized the this kind of process, but this is how we think of things. And so we identify the patient. If they have dialysis access in place, then we're going to use that as well. Um, and then we think of what are their current access options? Are they a candidate for two peripheral IVs, or do they have other needs? Are we going to put in a triple lumen central line where we could consider using one of those lumens? Um, and thinking through how we might use that. But typically, that's only when they either already have that access in place or are going to get it placed for some other reason. Maybe they need vasoactive medicines, other central loop access. And so our last kind of thought is if we can go there, we're going to place the two PIVs, ideally with the more proximal catheter as the withdrawal line. And if we're unable to place that or we run into issues, then we're going to proceed with the DULC placement. And so that's going to have been our overall goal for how we're going to treat these patients. Next slide. I think that was my last.
Great. Thanks, Kyle. Before we move on to this next section, let's address a couple questions that you have some expertise with. So one of the attendees asked, why does your center only do scuff and not modified CVVH? With Aquadex, have you had any clearance issues?
So we have just chosen that because we are a moderately low volume center. And so we wanted to gain expertise initially in using it for scuff. There are, risks with using the modified version, and that you're relying on a separate pump that's not integrated into the system. And so when doing that, and if you're not doing it enough, we just opted for we wanted to do it as per the guidelines, because our patient population that we brought the therapy in for was primarily the fluid overloaded without needing clearance. And so not saying that we will never go there, we just haven't gotten there yet because we're trying to kind of optimize what we're doing now. Um, and that being said, we have other machines that I won't talk about specifically, but other devices that can do CRRT well on little babies. And so we have just decided to use that on the smaller kids.
Yeah, we've done CVVH with Aquadex at Cincinnati on a handful of patients and have not had issues with clearance. For the small size babies, it works fine. I don't know if anyone else on the call has had experience they want to talk about regarding CVVH with Aquadex.
I'm happy to
Oh, you got
briefly
some.
just I'm happy to just briefly. So I would say 80 to 85% of our Aquadex treatments are done with in CBVH. And really the only place where you can start to have difficulties is when a patient is having so much intake that you are limited in the amount that you can ultrafilter, and that affects your clearance. So because of the way the pump is limited to 500 mils per hour, sometimes in larger children, that can sometimes be a limitation, but we have not had any difficulties, especially in smaller patients, achieving our parameters. We usually prescribe about 25 mils per kilo per hour, and that is enough to get us where we would like to be in terms of our clearance.
And then while we're talking about additional uses, has anyone on the panel ever done plasmapheresis at the same time as running aquapheresis with Aquadex?
We have discussed it, I'll say, given I've been at now two centers with a lot of plasmapheresis experience and use, probably the higher centers. And so probably I would venture, since we haven't, that I'm not sure there's any use yet, but it's been discussed, and in theory, I could see how a tandem therapy could potentially work. I will say most of the patients that require the tandem therapy require high clearance rates, and then oftentimes that puts us on an alternative device. So,
And then, Michelle, do you heat the replacement solution fluid when you use current replacement fluid for
We do
clearance?
not usually. It has not been a problem in our experience. If we need to do
No
anything,
way.
we just heat the baby or child.
Okay. Um, And then there's an access question I thought was worth addressing as the group. So, someone in the call had asked, do you find that neonatal post-op, heart disease patients are easily able to be accessed with dialysis catheters? What size? And this is often a barrier with the PrismaFlex CRT. And Dr. Starr had indicated that at Riley they use the 7x7 French central lines or a 5 double reinforced PICC line cut, which is what Dr. Merrill had mentioned. And at Lurie's, they're currently using 7.5 inch catheters for this patient population. Um, okay, let's return to the content now and cover the section on anticoagulation. Dr. Furman.
Great. And I'll get into a little bit of our catheter use too, naturally within this talk. I'll mention that yes, we do to kind of show our perspective or state it in the clearance realm with Aqua. Since you asked, we do use it or have used it in both centers I've been at for clearance. And I will say in the smaller patients, as Michelle mentioned, we similarly will check twice daily weights and do frequent assessments and usually using that crit line. As most of us do with any kind of dialysis treatment, we consider insensible losses certainly in our prescription. And we do accept and note importantly that we found that the effluent pump can have a discrepancy in what you program and the actual fluid removed of about 7 to 10% when we looked at it. So we'll sometimes, in those patients that we know are exquisitely sensitive, we might leave on, 3 to 5 milliliters per kilo per hour to achieve a net even fluid balance per se. And certainly happy to talk more about that offline. Or as you can see, this group is pretty enthusiastic about what we do. We love to share because it's helped our patients. So we hope these conversations continue. You can certainly reach out to the Nuwellis group and get in contact with us pretty quickly about elaborating on a lot of this. But talking about anticoagulation, I saw some of the questions alluded to this, so hopefully I can touch on it going into the next slide. So there's certainly options, as with any form, and we're pretty fortunate in now our world of critical care nephrology that there's certainly not just one option, whether that's good or bad. I think we've said a few times, finding a way you do things at your program and being consistent with that, and doing what works for your program in particular is important. The most commonly used form of anticoagulation for Aquadex is heparin. And you'll see when you talk to centers and also what's been published. There's key considerations here. Anticoagulation, as opposed to no anticoagulation, I think goes to say with any form of dialysis, is recommended to prolong the life of the filter. And thinking about administering the anticoagulation at least 30 minutes prior to starting therapy is important and something that we do at my prior center, my current center. And thinking about heparin, noted here are therapeutic targets to consider based on what your center typically uses for monitoring of heparin. I'll say our center had a protocol for this that I gained from talking to other centers and happy to share that in detail. And then bival and argatroban are other options that could be considered, again, with monitoring with PTTs and ACTs and antennaes in cases of HIT or heparin resistance, or based on your center's comfort with these forms of anticoagulation, certainly. There, as it noted here, just because it's been put out into some of the literature, the use of oral medications or low molecular weight heparin. Importantly, these options are certainly going to be more effective if you're thinking about it in short or intermittent treatments. I think a lot of us have alluded to when we use Aquadex, we'll use it for consistent 24-hour use or in maybe more like a PERT therapy of 6 to 12 hours. one would envision that these forms of anticoagulation might not be effective for longer therapies, especially in our smaller patients. Going on to the next slide. Um, so there's alternative, and just to know these options are out there. There's alternative strategies, thinking about potentially doing a continuous infusion, not weight-based, probably in our larger patients, more adult-sized patients. The value of the heparin bolus also may vary by institution, and I think can think about how you approach it for your traditional Prismax or Plasmaflex, or different, more traditional dialysis therapies, the way you might approach that. In terms of ECMO, we at my centers have not used it in tandem with ECMO. There may be some experience out there, but in places that may have considered this, may think about their ECMO heparin protocol and use that in use with the Aquadex. Priming circuits can also be done differently in terms of using heparinized saline, or following filter resistance values. Importantly, maybe a way to think about how you would titrate your anticoagulation. And then the options of a flush or a priming use of saline is another option. We've used this in patients in my prior institution who maybe we really felt any use of anticoagulation was undesirable. Maybe a patient with a head bleed, had a few situations where maybe a transplant surgeon says, I don't want this patient on any anticoagulation, yet they clearly need dialysis therapy. And we have used many instances of using this with different devices. I'll say personally, I haven't had experience using saline flushes with Aquadex. But I think Dr. Starr, I'd heard that your center may have some experience with this, in basically taking normal saline and drawing it up at timed intervals and basically flushing the access line at those intervals. If you have anything to elaborate on that,
Yeah,
Michelle.
I have a slide and a couple, so I'll jump in, I promise.
Oh, perfect. Perfect. All right. So moving on to our next slide here. So something that we adopted pretty quickly as we started using Aquadex, and I was just looking back at the picture of our center. We were pretty excited when we started using it, specifically on September 3rd of 2022. Was remembering when that was. We had said we're going to use heparin, and because this is what's most used at most centers, but we're a center with a lot of fulminant liver failure, and we found ourselves gravitating a lot towards the use of epoprostenol and other forms of CRT. And with that, we pretty quickly adopted this practice with our Aquadex, so which is why I wanted to share some of this with you. Our data here is soon to be published. Again, happy to elaborate more after the meeting with anyone who's interested. And essentially, we infuse the epoprostenol pre-filter via the withdrawal limb of the circuit using a dedicated infusion pump. And we use the epoprostenol at a rate that is well below the use for traditional any kind of vasodilation or concerns that you might see in terms of those side effects. We're really aiming for just that antiplatelet effect. The initial infusion rate being 2 nanograms per kilo per minute, and our max is 9 nanograms per kilo per minute. And we titrate it towards circuit life, which I know is kind of a very broad, gross way of monitoring. We do monitor anticoagulation values, but unfortunately, there's no lab test that we can follow to look for adequacy of anticoagulation with epoprostenol. What we find desirable about this agent is that it's quick on, quick off, which is always a nice thing in the ICU. You're not really stuck with the effects of this medication if you have any side effects. But importantly, with it being a newer agent, we thought we'd look at it. This is in 46 patients. In general, these are patients that may represent some of the patients you take care of in terms of age and body surface area. fluid accumulation. And then our reasons, as I mentioned in one of the prior slides, most commonly in our unit, we're using the therapy for patients coming in a lot of times with an underlying renal reason for coming into the ICU, oftentimes though with sepsis or multi-organ failure or after solid organ transplant. Cardiac ICU was also a common reason or patient population that we did therapy in. Severity of illness, mild to moderate, if and based on we use PLOD scores, a common scoring system for severity of illness in kids. And then moving on to the next slide, can show you a little bit in terms of our access, just even aside from the anticoagulation. And so this is the different types of access that we've had success with at our center. As you can see, there's some variety here. I was really interested to hear Dr. Merrill's talk. That's exciting to think of broadening this in terms of moving away from really the central access necessities. So again, happy to talk more about that offline. Our form of therapy most commonly being scuff. And so what we looked at here is the median, and what we're just interested is efficacy, our median filter to day ratio. So filters are going to last 72 hours at a maximum here. And what we found is that ratio with epoprostenol was pretty good, 0.5, a half a day per, or excuse me, half a filter per day, and a medium number of interruptions for clotting being 0 to 0 to 1 in the interquartile range, also pretty desirable. Moving to the next slide. And then so just lastly here, safety. We just looked at, changes in platelet values, which, multitude of reasons why platelet values appear to be going up prior to treatment and then 72 hours into therapy. They weren't, our question was, were platelet values coming down? And then also we looked at vasoactive ionotropic scores or VIS. And here, this was not statistically significantly different, although it looks like there's quite a drop in score. But our big question was it going up? Were patients requiring more vasoactive medications with the use of epoprostenol, more from a safety standpoint? And that appears to not be the case. We looked at bleeding events, and that was also none to be directly attributed to the epoprostenol. So just providing another alternative way of anticoagulating. And I saw one of the questions was in regards to regional versus systemic, and this is thought to be a more regional form of anticoagulation, and certainly in a lot of our patients that's really desirable as opposed to systemic anticoagulation. So moving on to the next slide. And I think this is
Yeah,
your
so
spot, Michelle. Yeah.
perfect. So I can just jump in real quickly. So we have a pretty significant number of patients where the preference of our intensivist colleagues, whether it's NICU or PICU, is not to anticoagulate. And so I'd say particularly in our NICU, this is pretty much our standard approach. So we use a approach where we are using a flush and reprime sort of approach. So what we do in this situation is that we use normal saline flushes, which we put in line to the circuit to dilute down the filter and decrease the chance of clotting. And then sometimes we will actually disconnect the patient and reprime the circuit. One of the really nice things about, Aquadex as opposed to kind of some of our other modalities is that you can identify when a circuit is starting to really develop those smaller clots and intervene. And so we have actually been able to kind of come up with a protocol. So what we do in patients like this, we will often do a heparinized saline prime. So we will heparinize saline, prime the circuit, then rinse that with saline. So all you are getting is a little bit of adhesion of that heparin to the filter. And then we will do scheduled flushes. So this is actually built into our order set when we decide not to do anticoagulation. So we do 20 ml scheduled flushes every 4 to 6 hours, depending on what we're seeing in terms of our filter pressures. And then we have a PRN filter pressure order when the resistance goes above 1. You do need to remember, and when you're kind of building your program, you have to make sure that you are removing that 20 ml flush the next hour so you're not accumulating fluid. But this has become our standard in some of the units where we do not want to anticoagulate patients and has been highly successful with kind of these standard parameters in place.
Very cool. Thank you. And next slide. I think that ends that portion. I'm happy to take questions.
Yeah, thanks, everybody. We're a little bit over time. We've had a pretty robust set of questions answered, I believe. I'll just put one last question forward because I think it might have some general applicability. One of the attendees asks, does any institution or speaker have experience in pediatric burn patients? This person's at a mixed adult peds hospital with a large burn population, and they're trying to understand how this might be an option for them.
Gosh, I can see how it would be, but I will say I don't have experience specifically in burn patients,
I was going
personally.
to say the same thing as the good Dr. Fuhrman.
I do believe, Coop, that we can answer this through Nuella's channels for the sites that do have that. I don't believe anyone on the call today has that experience.
Great. And then another question regarding access about using experience with access in single ventricle patients, specifically Norwoods. I would say that we have had we've generally not accessed their upper extremity. We've used lower extremity access for these patients. It has worked reasonably well. Particularly when a larger size line is used. We have also done transthoracic access in the past for some patients, and have done upper extremity, but mostly either lower extremity or transthoracic access. I think for the sake of time, that's probably it. There are some other questions that people can follow up with. Well, maybe one last question. How often do you find the need to transition from peripheral access to central access? Kyle, do you want to take a stab at that?
Yeah, I think we're still a fairly new center and don't have the robust numbers that others do, but I feel like it has happened in a couple patients where um oftentimes I think these littler, PIVs and the peripheral IVs will just have more likelihood to clot, and we often just move to a more central catheter. But I would say for a couple of the patients we've had very good success using the PIVs for multiple treatments. So I'd say I don't know if I could give a number out, but I would say it's less than half of the patients go on to need more central access.
The power pick option is a really great
Yeah.
option because those catheters are designed for high power injections. So at these flow rates, it's really a very interesting alternative to standard central access, particularly in the smaller of our patients. Okay. If you registered for the webinar, the recording will be available on demand by the end of today. Here's some contact or detailed Noella's contacts both on X, LinkedIn, YouTube, and the corporate website. Next slide. The last slide.
Yep.
This should
I think that is the last
That's
slide.
it. Is that the last
Yep,
slide? Okay.
it is.
All right. Well, thank you all for joining the webinar today. Thanks to Doctors Furman, Merrill, and Starr, Teresa, and the Nuella's team for making this a valuable presentation and a very productive discussion. We had over 200 attendees, which is great. As I said, this webinar will be available on demand by later this afternoon. And then lastly, if you'd like to speak more about pediatric ultrafiltration with Aquadex, you can reach out to your rep or email balance@nuellis.com to get connected. Thanks again, everyone, and have a great day.